All right, started the recording. So, want to get started? Okay. Thanks everyone for coming and for dealing with our last-minute room change and minor technical difficulties. We got it all sorted out in the end. We're very happy to have you here. I'm very pleased to introduce Michael Connolly, who served as CEO of one of the largest healthcare systems in the nation, the CEO of Mercy Health, formerly Bon Secours Mercy Health. His book is currently out. It's called The Journey's End. It's about death and dying in the modern society. And without any further ado, I'd like to hand it over to Mr. Connolly. And thank you so much for coming.
Well, thank you, Matthew, and not only for that kind introduction, but for all the work you went through to facilitate this presentation. I do want to apologize for not being in person, but a recent hip surgery made that travel option a little unrealistic for me. So video conference it will be. But I do hope we have lots of questions and have good interaction. That's the best way to learn. I believe my remarks today will tie nicely with the humanities focus of this seminar series. From my perspective, humanities has never been more important to the future of healthcare. My particular topic assignment for the seminar was titled, "The U.S. Healthcare System, Can We Do Better?" This assignment fits nicely with my lifelong passion of trying to reform and improve healthcare. Throughout my close to half a century in healthcare, reform has been constant, but unfortunately, most of that reform has actually made healthcare worse. My career has involved leadership positions with two of the largest U.S. Catholic systems in the U.S., Ascension and Bon Secours, spending 20 years with the first and 22 years with the second. I also practiced law in Chicago with a large firm. During my career, I had the opportunity to work with academic medicine, community hospitals, manage large medical groups, run health insurance companies, nursing homes, rehab centers, home health agencies, and hospices. I also had the opportunity to study health systems in advanced European countries, as well as to look at primitive healthcare in the world's poorest countries. I spent my last 22 years trying to build an integrated delivery network out of 35 independent community hospitals covering several states. Based on these experiences, I humbly come before you as a simple yet passionate advocate for health reform that can make healthcare better. My greatest concern today is that healthcare has lost its soul, its sense of humanity. The healthcare treatment model has evolved from one focused on personal relationships to one satisfying transactional operating requirements. This duality was identified by Dr. Bufel in his lecture, The Normal, the Pathological, and the Perfect, when he discussed and compared the biostatistical model of care to the holistic model of care. And while the literature has much discussion about the importance of holistic care, the actual delivery model today has no interest in holistic care. The new transactional model is driven primarily by clinical and economic forces. Today's practice of medicine is increasingly being taken over by the operating requirements of insurers and health systems. These burdensome operating requirements are the result of flawed health policy, misaligned economic incentives, insurance design, an over-reliance on evidence-based medicine, and the legal environment. Understanding how and why these forces operate is the key to finding a meaningful path forward for improved U.S. healthcare. So let's go to the next slide and look at the current state of healthcare. It is dire, if I were to put it in one word. Public and provider satisfaction has been documented at all-time low based on a variety of public surveys. Costs are enormous, $5 trillion annually and getting much worse. And the quality outcomes are poor, with the U.S. ranking last compared to other advanced countries. Of course, we can do better than we're doing right now. especially with the resources that we're spending. But the answer isn't very clear and hasn't been. I noticed in your readings for this lecture, there were 2 articles on the history of reform of the U.S. healthcare. I've lived through most of those. And they have all been rather significant, but at the end of the day, it's been nothing but a compounding complexity that has actually made healthcare worse. So let's move to the next slide and take a brief overview of U.S. health statistics. Nearly 40% of Americans are pre-diabetic. More than 1 in 4 12 to 19-year-olds are pre-diabetic. 3/4 of Americans are overweight. More than 107,000 Americans died of a drug overdose last year, far exceeding that of any other country. U.S. life expectancy is 5 years shorter than the average comparable country.
We managed to work out the problem.
Pardon?
No, that was Matt.
Is there a question?
No question, no.
Okay. And then the last point that's not on the slide is that the average senior citizen in the United States is on 5 drugs for a chronic illness. And so while we have the most advanced healthcare in the world, we have poor health outcomes for the nation. And I would say that the primary cause of these problems is the design of the U.S. healthcare system. So I will be focusing on how we might redesign healthcare in the United States. Move to the next slide, please. Here's a graph that compares a number of the countries that I had an opportunity to study healthcare in, and their life expectancy and their level of expenditure per person. And as you can see, those countries have much better health outcomes and literally spend half of what the United States spends on healthcare. And what primarily separates all of those health systems from our health system is the fact that they're built more on a primary care system than they are on a specialist system. And that is, I think, the key design difference that we need to embrace more in the United States. Let's move to the next slide, please. Now, one area that I would target for improving healthcare besides primary care would be our approach to care for people at the end of life. It is unfortunately been studied extensively. There are massive studies by NIH and a lot of other reputable organizations, panels from all across the country that have recommended significant changes for end-of-life care in the United States, leading with the back in 2006 when they created palliative care as a specialty. Unfortunately, none of those recommendations and the specialty of palliative care have essentially not been integrated into healthcare overall. And as a result, we have an over-medicalized approach to dying. 25% of hospital beds are occupied by patients in their last year of life. Frail elderly people cycle in and out of hospitals. Nearly 33% of emergency calls involve patients near the end of life. These patients often end up in intensive care and on life support. Many do not wish to be hospitalized or die in a hospital setting. And dying patients receive high-intensity care without clear benefits at odds with their known preferences. So this issue of overtreating the frail elderly isn't an accident. It's really by the design of healthcare and the fact that patients aren't educated about their choices. They don't honestly have much informed consent about end-of-life care. And it is a derivative of our culture as well, that nobody wants to talk about dying. And that fear of having a conversation, whether you're a provider, a family member, or a patient, is a root cause of why we have this healthcare outcome for the elderly. Let's go to the next slide, please. The next area that I would highlight is the shift from a relationship-based treatment model to a transactional-based treatment model. And it actually has a clinical focus to it. Physicians are increasingly being trained to go through a cycle of they evaluate the patient based on tests, they assign a diagnosis, they use evidence-based medicine, and then they code the care. Now, this can occur without really learning much about the patient, their life, or their concerns, or their priorities. And frankly, the way the system works, doctors don't have time to get to know any of that stuff. It's basically a data-driven activity that could easily be taken over by AI because it's all about evidence-based medicine and algorithms. Now, Professor Jordan Wales highlighted the dangers associated with blindly relying on AI for clinical decisions. Clinical decisions are certainly enhanced greatly by artificial intelligence. It is a great tool, but ultimately the final decision about care for a patient needs to be made by a human being. And that decision needs to integrate into it an understanding of the patient, otherwise known as the art of medicine. But in order for doctors to practice that art of medicine, they need to have cultivated a relationship with the patient in order to practice the art effectively. Next slide, please. Now, another outcome of our care model is that it has become siloed and fragmented. So when I was starting out in healthcare, there were only 22 specialties. And today, I believe there are over 250 specialties. And that explosion in terms of different people caring for people hasn't been nurtured in terms of how to have all those people talk to each other and coordinate care. And in place of that communication and that coordination, people rely almost exclusively on science to treat their patients. But that sort of ignores a lot of other elements and why handoffs are always such a problem in healthcare. But an invidious reason for all of this is the payment system. The payment system pays for costly procedures while they'll pay very poorly for cognitive care conversations, which can actually help conserve costs and promote population health. I mean, I find it absurd that there is absolutely no restriction to having a dying patient in ICU, but we can't give home health to somebody in hospice. Those trade-offs don't make sense to me from a holistic point of view. The specialization of medicine, which is obviously a tremendous benefit and has done great things for the advancement of treatment, has also created silos and fragmented care that the transactional nature of healthcare has made even worse. So care coordination and fragmented care are now one of the biggest issues in healthcare overall. Next slide, please. So what we've identified is that we have end-of-life care, which is over-medicalized. We have major problems with the loss of relationships with the patients, and we have a serious problem with fragmented care and care coordination. What might be one way to better address all of those problems? And I think that the pretty clear answer to that, based on evidence, is that primary care being expanded and re-empowered to be responsible for the relationship with the patient and with the care coordination would do that. And again, as that earlier slide illustrated, that countries that allocate more healthcare spending to primary care have better health outcomes, they have increased life expectancy and lower mortality rates. A robust primary care system enhances preventive care, early diagnosis, detection, and management. Now, there's a lot of criticism today of the effectiveness of primary care. And there are some legitimate reasons for that because they don't have time to do what they're supposed to do. And so they do have a tendency to quickly refer to specialists and don't end up doing that care coordination. But the reason for that kind of goes to the last bullet point, which is the US healthcare system only spends 4% of healthcare dollars on primary care, while the 10 advanced nations with better healthcare outcomes spend 14% of their healthcare dollars on primary care. And sadly, Medicare, which has the population that needs care coordination the most, only spends 3.4% of its dollars on primary care. So re-empowering the role of primary care in healthcare is critical to improving the future of healthcare. Next slide, please. Now, if all the issues we've discussed so far aren't enough to stimulate change, it's going to get a lot worse. So if I said it's dire today, it's going to get a lot worse. So today, there are 37 million individuals on Medicare. But by 2030, it's estimated there will be close to 78 million people on Medicare. So if we have a cost problem today, think about how that cost problem is going to be when we have that many more people on the Medicare system. At the same time, we have a demographic change whereby the population that supports the pay-as-you-go Social Security and in part the pay-as-you-go Medicare system by the workforce. But a few years ago, we had 7 workers for every retiree. By 2030, we will have 2 workers for every retiree. So the pressure for fixing things is going to increase rather dramatically over the next 5 years. Next slide, please. So why is primary care so dysfunctional in the US today? And I think that there is a very simple reason for that. And that is that fee-for-service billing does not work for primary care. Primary care is not a measurement procedural specialty, but fee-for-service is a procedural measurement payment system. And no matter how they try to add codes and try to enhance primary care, they actually make it worse. I chuckle when they tell me that they've added all these new codes to help primary care make more money. But what they don't talk about is that in order to get that money, there are 10 documentation requirements on quality that they have to provide, and that the billing system costs of doing that documentation and doing the billing far exceeds the modest increase in payment they're going to get from that payment. So the whole point is that paying it all for primary care with fee-for-service is a disaster. And fee-for-service causes more problems than just primary care, but my focus is on the fact of its destructive nature. Every year, the Milbank Fund does a primary care scorecard on the future and the past of primary care. And every year for the last decade, there are fewer doctors going into primary care. There are greater gaps in access to primary care. And every year we spend less on primary care. Coding by its nature allows no time for compassion, conversations, or building trusting relationships. Now, most of my career, there was this new alternative that is no longer new, which is called value-based payment. And for most of my career, this was going to be the salvation to fee for service. Well, first of all, it never got adopted. It's still a very small percentage of payments in healthcare. Second is that it only works if you have an integrated delivery system to support it. And most of America is not organized into an integrated delivery system. And lastly, value-based payment relies heavily on the coding system, which allows it to be manipulated. One of the other bad things about coding is that there's a lot of gray space in coding. And that gray space has invited greed and manipulation. The best illustration of that are the Medicare Advantage plans in the United States right now. Medicare actually started Medicare Advantage to use value-based care to lower the cost of Medicare. And right now, Medicare pays Medicare Advantage 106% of what it pays for traditional healthcare. So it's paying billions more for patients enrolled on these plans that were supposed to help save money. And the reason they end up paying more is the coding system. And that's a whole topic in and of itself. So I'm going to stop there and we can go on to the next slide. So the consequences of this payment system and this diminishment of primary care and medicalizing the elderly has been that the billing system itself now costs $1 trillion annually. And that is a T, not a B. When I was in college, the entire US GDP was $1 trillion. It's a lot of money. And basically, that $1 trillion doesn't do anything to help patients. Another signal as to how invidious this billing has become is that over the last decade, there's been a new business that has arisen that's got the wonderful acronym of RCM, Revenue Cycle Management. And it is now a multi-billion-dollar business. And essentially it exists because hospitals and physicians are overwhelmed by the complexity of the coding and billing system and have to outsource it to these revenue management companies, which become experts in figuring out how to manipulate the coding so they can get better payment. Second point is that all of the time of physicians has been diverted from caring for their patients and building that relationship to spending hours and hours documenting information required by the complex system that we have. And one of the sad things about one of the reforms of healthcare is that the electronic medical record was supposed to be one of the great benefits to helping integrate healthcare. And unfortunately, the entire electronic medical record today has been hijacked by the billing system. And so now the record is not really arranged for helping document patient care and measure quality and communicate information. It's designed for billing. And that corruption of the electronic medical record has made that whole system much less effective. Finally, there's been an explosion of emergency rooms and urgent care visits because we don't have anybody in primary care. And the problem with ER visits and urgent care visits is that all they do is compound fragmented care. None of the information from those gets integrated into the patient's profile very effectively, and it ends up causing all kinds of problems. And so all this is examples of fragmented care. Next slide, please. So another aspect of the design of healthcare today is its focus on what I'll call the acute care treatment model. And the acute care treatment model does not work well with chronic illnesses. But when we look at the US health and the US population, what we see is massive amounts of chronic illness. But yet we use a treatment model, acute care, that isn't responsive to the nature of the illnesses of the population. So 52% of the population has a chronic illness. 42% of Americans have more than two. 90% of the nation's dollars go to chronic illness. 99% of Medicare and 80% of Medicaid goes to chronic illnesses. And so chronic illness is what we're treating, but the treatment model of acute care is not very responsive to the needs of those patients. Next slide, please. So what do I mean by the acute care treatment model? Well, it's specialty driven, it's procedure and test driven, it's evidence driven, it's outcome driven, it's measurable and codable, it gets good reimbursement, and it's less dependent on the patient's behavior or knowledge. Unfortunately, this works great, for open heart surgery and hip replacements and many, many things. But it doesn't work well for a patient with a chronic illness. Next slide, please. Now, the chronic care treatment model has a very different focus. In that model, care coordination is critical. Treatment is based on having time to talk with the patient and know the patient and understand the issues. Caring for that population requires a lot of conversation. I'll never forget an orthopedic surgeon friend of mine talked about how much more complex it was for an aged patient that he's got to talk to the children, he's got to talk to the patient repeatedly, just to understand what's going on. All that conversation is not paid for in the system. Whether you have it or you don't have it, you get the same amount of payment for that surgery. Care results for chronic illness are more dependent on patient behavior. Again, if you want to help change or improve patient behavior, you have to have some time with the patient. Sadly, much of this care isn't codable, it's poorly reimbursed. And honestly, it is less appealing to most physicians. You're not fixing a problem. You're basically helping someone live with a problem. That's not as rewarding as fixing a problem. And that's what palliative care and hospice were supposed to be for. Unfortunately, they didn't get integrated into healthcare, and so they're not there taking care of those problems. Next slide, please. This is just a summary of the differences between the two. And I've already covered them, so I'm not going to repeat that all over again. But this is just to give you a simple summary of how the acute care model and the chronic care model differ. Next slide, please. Now, this information comes from Northwestern Medical School, which had a particular interest in palliative care. And their concern was that palliative care was not very well understood by physicians. And so they wanted to try to do some research and find out why. And these were some of the key conclusions that they came up with in that research. The first is that physicians have almost no exposure to the concept of palliative care, which also means they have very little exposure to chronic care management in their training. Second, they observe that physicians are so busy doing things that they have very little time to think. And a lot of care for chronic illness requires time to think. And they observed that it's easier for a physician to treat than it is for a physician to listen. That it takes time to plan, review things like advance directives, and deal with families. And finally, uncertain prognoses make physicians uncomfortable. It used to be that prognosis was an important role of the physician. You almost have no work with prognosis anymore. Part of that is the legal environment, that people are afraid that they could be sued if they projected something that wasn't going to happen. So they're only going to advise on things they know will happen. But that's something that, from a patient point of view, is prognosis is very helpful. Next slide, please. So I thought I would take the difference between chronic care and acute care and illustrate it with a patient case. And the patient case happens to be my sister. My sister died in 2011 after a good 15-year run with COPD. She was a very heavy smoker. In her early 50s, they started to try to describe to her what was wrong with her. And what I found interesting is they didn't seem to want to tell her she had COPD. And eventually that's what everybody agreed the issue was. But with my sister, again, there was no prognosis. I mean, what's going to happen to a COPD patient over time is fairly clear. In my sister's case, I could just walk through the scenarios. I mean, in the first several years, she sufficed with inhalers. And then the next several years, she went on oxygen, and oxygen went from, a few hours a day to 24/7. When those two were insufficient, then she went to steroids. Now, the steroids were what were needed for her to continue, and that was sort of a sign that things were going south. But the treatment of her care with steroids is a good illustration of acute care versus chronic care. Now, her pulmonologist, rightly so, based on evidence-based medicine, was very careful about her access to steroids. On the other hand, she's dying. She's probably got a couple of years left. And any damage from the steroids is going to be less serious than not having the ability to breathe. But he had a rule that she couldn't get a refill on her steroid unless they had a doctor's appointment. And lo and behold, she had an episode, and the physician was on vacation, so she had no access to her steroid. She went to the emergency room. The emergency room misdiagnosed her completely. They thought she had a heart problem, which she had symptoms that would maybe have led to that conclusion. She ended up with a 2-day hospitalization with a complete workup for heart issues. And when she got out of the hospital, she said it was the most torturous experience she'd ever had, and she never wanted to go in the hospital again. And so I said to her, well, let's try a different care model. And I specifically suggested that she look at palliative care, and she wasn't sure what that was. And she asked her primary care about it, and her primary care doctor really wasn't familiar with what that was. Of course, this was 2011. But nonetheless, he did arrange for a hospice to come visit her. And a nurse from the hospice came and spent about 2 hours with my sister, interviewing her. And my sister said to me afterwards that that has been the best care experience she'd had in decades. And whatever this thing is, that's what she wants. And it turns out that she was eligible for hospice. And this is another psychological issue. If I had told her that she needed to go to hospice, she probably would have fought that. She wasn't ready psychologically for that. And that's why calling it palliative care was a nuance. And then once she got exposed to what the care was like, that's all she wanted. She had, I would say, about as good an experience with hospice as one could have. She got to spend time with her family. She was never hospitalized again. She was never in great pain. And she really had as good a life as she could have for those last 5 months. But my point, and then here's another example of the acute care intervention. But the pulmonologist, before she was going to go down the path of the hospice, she said, well, you could have a lung transplant. Well, a lung transplant in 2011 wasn't nearly as advanced as it is today. It was incredibly expensive. And in her case, she had a lot of poor health issues, and I don't think she would have been a very good candidate for a lung transplant. And she was borderline being eligible even because of her age. But nobody talked about palliative care. Nobody talked about hospice. All they could talk about was restrictions on steroids and lung transplants. And so that's an illustration of how the acute care model does not serve a chronic patient that well. Next slide, please. So we spent a lot of time talking about what's wrong. Now we need to spend some time talking about what we can do about it. And I sort of put some guiding principles together as to what I used to screen what I came up with as to the solutions. My first is that we need to focus on simplicity. We can't propose a system that's complicated. It needs to be implemented without a lot of documentation and a lot of issues that make it difficult to implement. Second, we need to focus on incentives. People do what they're incented to do. Third, we need to focus on culture. We need to understand that people won't do certain things, and if we can't design a system that people won't listen to, so we have to design it in a way that they're going to be responsive culturally. And then fourth, we need to be targeted in our choice for change. We can't fix everything at once. There are a lot of problems out there. So what we want to do is pick a few areas that will give us the most benefit for the least effort. And so those were the screens I used to come up with the next slide, which is 5 recommendations for change. Now, I've talked about reforming primary care, and I have very detailed plans spelled out in my book, by the way, on how you would change and improve primary care, eliminate billing, eliminate payment based on fee for service, and expand their role for care coordination, and add to their role taking on end-of-life care coordination. Second, I have some very specific recommendations on making end-of-life care work better. A lot of that has to do with improving the informed consent of patients and families, and doing that by making palliative care and hospice more accessible. Now, most people are very aware of hospice. In fact, over 50% of patients actually do use hospice. But the problem is the average length of stay in hospice is 18 days, which is sort of totally defeating the purpose of hospice. And so we need to change the benefit and change the attitude for viewing hospice. People actually live longer in hospice than they do in active treatment. The third area that I actually haven't talked about, but is a pretty straightforward issue, is we need to get insurance companies out of challenging physicians' clinical judgment. The idea, and it's getting worse because insurance companies are now using artificial intelligence to use evidence-based medicine and combine those two to deny care. And when you look at it from kind of a legal point of view, the insurance company becomes the total authority without any sort of balance of power between different points of view. And so, in my opinion, the clinician's point of view should be the dominant point of view. If the insurance company wants to challenge it, it's their burden, not the clinicians, to challenge it. And then if they do challenge it, they don't get to challenge it to themselves. They have to challenge it to an independent third party. So I'll talk a little bit more about how that would work. And then fourth, I would look at restoring the balance of art and medicine in medical education, and make chronic care and those issues around preparing doctors for treating patients more balanced than it is today. And then finally, another kind of off-the-wall addition is we need to change the U.S. food system. The U.S. food system is a real cause of a lot of the chronic illnesses in the United States, and we'll talk a little bit about that. So I'm now going to go through each one of these in a little bit of detail. There's a lot more detail on each one of them in the resources that I offer you, but I'll give you hopefully a thumb sketch on how each works. So let's go to the next slide. The first is primary care. So how do I eliminate fee-for-service from primary care? I have each insurance company contract directly with each primary care physician. They end up doing this anyway for their insurance, so it's not a big deal. And if a doctor doesn't want to sign up with an insurance company, doesn't have to. And if a company doesn't like a doctor, they don't have to. But I'd rather use that level of negotiations and use that to decide whether they want to go with somebody or not go with somebody. And then they would be paid a salary directly by the insurer. And so when you hear about doctors being employed, it makes no difference that they're employed. If the insurance company is still paying them on fee-for-service, the employment model is going to be based on that fee-for-service payment. This eliminates the use of fee-for-service. It creates a salary. Basically, the doctor's paid for their time, and their time is to take care of their patients. There are some questions about productivity and so forth, but I am more optimistic about primary care and their ability to take care of their patients. I would then take the other piece of the cost of a primary care practice, which is all of their practice expenses. So it's the office rent, it's the insurance, it's the electronic medical record, it's all the staff. And I would reimburse them based on something called reasonable costs. That's got an actual precedent for it in healthcare. Every hospital for the last 40, 50 years has filled out a cost report. Hospitals actually used to be paid completely through that model. My premise here is that primary care offices are not that expensive. As you look at the total cost of healthcare, it's 4%. So all of these expenses are not great and don't require a complex system to decide how much to pay. Come up with the simplest system to pay them and let them do their thing. The next thing I would do is make primary care a fully insured benefit. So there is no denial for going to a primary care office. There's no co-pays. There's no co-insurance. Again, the idea is to incentivize patients to go to the primary care office to coordinate their care so that we have a home for the care of the patient and it's coordinated. And then finally, I would add a responsibility to primary care, which be the person responsible for the end-of-life conversations. Now, I honestly know that a lot of primary care doctors may not be interested in having those conversations. And that's okay because it's very effectively handled by a palliative care nurse. So practices could hire, again, with a reasonable cost reimbursement, a palliative care nurse to do that. And then instead of going to lawyers' offices to complete your advance directives, you would be directed to go to your primary care office, and then you'd have updated conversations on those directives. So those are the reforms to primary care. Let's go to the next one. Hospice, and this may get a little technical, but basically hospice is designed in a way that makes it very unusable. So the first requirement of hospice is that a doctor has to certify you're going to die in 6 months. The most absurd thing about that is that there's no clinical evidence to be able to know if somebody's going to die in 6 months. And so doctors are reluctant to even talk about hospice to a patient because they don't want to say they think you're going to die in 6 months. And that's why we have 18-day length of stay, because they wait until they know for sure they're going to die, and then they bring it up. So it has a chilling effect on using hospice. Instead of that, which the original purpose was, if you have a terminal illness, you should be eligible for hospice, period. If you've got a terminal illness, you're eligible. That's what the original role of hospice was. Medicare, some actuary came up with this ridiculous rule. Then the next ridiculous rule that Medicare has is that if you're going to go into the hospice benefit, you have to give up your regular Medicare coverage. Well, that has a chilling effect on the patient. The patient doesn't want to give up the right to maybe get care or go to the emergency room or have some coverage. And so they're reluctant to go into hospice until the very end for the same reason. However, there's a lot of evidence, and actually there was a trial project done by Medicare where they gave patients both benefits simultaneously. And the results were amazing. The results were patients predominantly used the hospice benefit. They were much happier, much more secure, and they didn't feel they were denied right to care. And it had higher quality results, and it had significantly lower costs than traditional Medicare. And then, as I mentioned on the last slide, EOL would become a job of primary care. And then the last point I would make is that I would make palliative care consults a requirement for any patient with a palliative care with a terminal illness. And I'll give one story as an illustration. There was a father of a family dying in ICU, very close to death, went into kidney failure, and the hospital sent in a nephrologist. The nephrologist said they would put the patient on dialysis. And the family, which was fairly sophisticated, said, well, he's dying, isn't he? Why would he go on dialysis? And they said, well, he could, he'll go into kidney failure if he doesn't go on dialysis. They said, well, we understand that, but that doesn't make any sense. He says, well, then maybe you'd like a palliative care consult. And to me, this is illustrative of how healthcare works. They immediately go to the acute care treatment instead of first having a conversation with the palliative care doctor to help decide what is more holistically best for the patient. So let's move to the next slide, please. And this is where we limit the ability of insurance companies. There's no real logic to the fact that insurance companies get to override clinical decisions. And not only override them, but then decide the terms upon which a reevaluation occurs. And then they are the final judger of the outcome. I mean, it's a total abuse of authority. They aren't the experts. They aren't the one that has a relationship with the patient. They're about as removed as they could be. The burden of proof should be on them. And if they want to challenge it, then they should go to a third party, which would look at them. And I think if you set up a model like this, you would pretty much eliminate the insurance companies interfering with the practice of medicine. Next slide, please. Now, on medical education, what I would like to see occur to help strengthen the art of medicine would be to increase the training of physicians on having difficult conversations with patients. This is probably one of the most challenging things a physician does during their career. And there really isn't a thoughtful way in most programs of addressing that issue. Next, we need to increase physicians' appreciation for the chronic care treatment model. I'll give you an example. There's a huge problem with nursing homes admitting to hospitals. And a lot of those admissions are triggered by medical directors of nursing homes. And that's because those nursing home medical directors are trained in the acute care model, and they see a symptom and they go to the hospital. We all know that that cycle is unhealthy and doesn't help anybody. And in lieu of an acute care treatment model, if you had a palliative care doctor as the medical director, and they could begin having conversations with families at quarterly clinical conferences and sort of talk about what do we do if, to avoid that vicious cycle of going into the hospital. That's an example of what I mean by increasing that training. I think the referral process, when you go from 22 specialties to 250 specialties, how they relate to each other and how they communicate, there hasn't been much science given to how to do that or any protocols on how to do that. It's just write a note in the chart and bingo. It doesn't seem to work very well. I have a particular bugaboo about the fact that we're expanding the use of these nurse practitioners, which are great. And I actually think in primary care, they're going to be very critical because, 50% of primary care visits don't need a doctor. But the issue is they're never trained in a consistent way as to how to work with a physician. And so, and that goes back to the medical education itself. Those nursing students and medical students should begin to look at models of how they would work together once they go into practice. And I don't think there's much research done at all on the best way to do that. And then finally, the last thing would be to increase the importance of nutrition in the education of physicians. Next slide, please. Now, I'm going to just quickly go through these so we have more time for questions. But basically, the food system in America is a mess. I think one statistic that I find most interesting is that in the United States, there are over 10,000 authorized chemicals applied to our food. And in Europe, in the European Union, there are only 400. So 10,000 versus 400. That was quite poignantly displayed recently when Secretary Kennedy came out with trying to take food coloring out of food. And they took a box of Fruit Loops and they showed the ingredients of a box of Fruit Loops in America and a box of Fruit Loops in India. And the ingredients in India's were half what they were in America. And basically, it was all the food coloring issues. So I'm just going to skip through these next few slides on the food system so we can get to the end. Next one. All right, right here. So there, stop there. So essentially, I'm recommending 5 targeted areas. So it's limited. They could be implemented without a major disruption in healthcare. They would, I believe, leverage a big benefit. And there's lots of evidence to support them. So it would be improving primary care, improving end-of-life care, getting insurers, companies out of clinical decision-making. Those could be done in 12 months. And then the issues of medical education and the food system are longer, gradual changes, but I do think that they could be steadily improved as targeted opportunities. Next slide. So these are some resources that I have available to you. Hopefully, I have conveyed my passion for the need to reform healthcare. I have done a lot of study over the last 7 years on the details of the health system to kind of come up with these specific areas for reform. And I believe that these changes would also do a lot to return humanity to healthcare. And so with that, I'll close, and I'd love to answer any questions.
Thank you so much, Mr. Connolly. Are there any questions from the audience?
This is Joe Buffil. I just wanted to thank you for that talk. As a physician who's been in practice for 30 years, I think you have presented a very accurate reflection of a lot of the problems in our healthcare system. And it was a challenge that we made to you, and I think you've done a great job in presenting an overview of the problems and solutions. I think, as you kind of mentioned, the problem is a dehumanization of the healthcare system. And this kind of goes to what we're trying to do with the Burr Oak Foundation in the sense of restoring a proper understanding of what a human being is in academia and in medical education. So thank you for contributing to that effort. Most of our audience here are younger medical students who have their careers ahead of them. So I think one question that we could address to you is, what would you tell these students who are looking at 3-4 more years in medical school and then another many years in medical training? What should they look out for, in a sense, so that they retain a sense of the humanity of their patients and not get distracted or swept into a mindset of understanding patients as economic values, or the type of situation that we find ourselves in today?
Well, one thing I would focus on is that it's easy to blame people for these problems, like the CEO of United Healthcare. I mean, people get so mad at how things work. But what I was trying to emphasize is that we've designed the system to do this. So people are really just implementing what we have designed. And so if we're going to fundamentally change healthcare, we have to come at it from the design point of view. And so one issue that's a bit altruistic, but would be the importance of advocacy in this. The other is I had a phrase in the talk about the over-reliance on evidence-based medicine. And I went hook, line, and sinker for adopting evidence-based medicine for quality improvement. And I was just overwhelmed with thinking it would be the great improvement in. And what I've learned is that a lot of that evidence-based stuff is very reductionistic. So, for example, if you look at the annual physical for Medicare today, it has a checklist of 50 things that the doctor has to go through. And they end up going through that checklist instead of having a conversation with their patient or finding out what the key issues are. And so this reliance on checklists and this reliance on evidence that's very reductionistic isn't wrong. It just isn't very complete, or it isn't very whole. And but it's easier, it's more black and white for you to look to that than it is to use your own judgment. And I'm a big fan of intuition and experience. And you're about to get all your intuition and experience loaded into your brains. And as you get that, don't disregard that as you go forward in terms of what you think is the right thing to do for a patient.
Very much.
Thank you.
Do you have any questions over there before I ask mine?
We have a question from
Terrific. Go right
John
ahead.
Williams, MD, PhD candidate here at Michigan.
Hi, Mr. Connolly. Thank you very much for speaking to us today. I had a question related to the primary care model that you proposed, where physicians received a salary from insurers. And you remarked that it would be important to make sure that productivity is still incentivized. And I was wondering if you could talk more about how, in that model, you'd still incentivize that.
So let's talk about specific numbers. The typical primary care practice today has 2,500 patients, which is totally unrealistic, and which is why they don't have time to know their patients. That has caused the explosion of the alternative, which is concierge medicine. And in concierge medicine, the typical practice has around 500 to 600 patients. So I would suggest that the optimal practice for just a physician is that 500 to 600. However, if you had 3 nurse practitioners with each one of those physicians, you could get very close back to a 2,000 panel. And so in terms of that contract between the insurer and the physician, it may be that we don't do a specific number to begin with, but we do a 1-year contract, see how many people they take care of, what their expenses are, because it really is more important for them to manage a patient population effectively. Their concierge medicine has 1/3 fewer ER visits, 1/3 fewer hospitalizations, because the patients have access to their doctor. And so those are some of the numbers that would apply. Is that helpful to your question?
I think so. I guess, would there be some kind of baseline amount of patients just kind of as a benchmark in that first year, you think, or
yes,
would it be pretty open-ended?
I think a floor of 600 per doctor and maybe another 200 to 300 per nurse practitioner would be a floor.
Okay, thank you.
Any further questions from the audience? Lawrence.
Question from Lawrence, a first-year medical student.
Hi, Mr. Connolly. Thank you again for taking the time. And I feel like the point you made about nutrition education really resonated with me, because I've seen this chart on life expectancy versus health expenditure countless times. And I'm wondering, what are your thoughts on a lot of the other determinants that are involved, such as, for example, nutrition, and even some cultural factors that come into play surrounding nutrition and exercise and diet, or even the impacts of, let's say, late stage capitalism and a workaholic culture in the United States, where we can earn more, but we can pay off more for healthcare expenses when they arise urgently. And I guess maybe the East Asian nations in this chart, like Japan, would be an equalizer for that. But I'm wondering, what are your thoughts on the role of the primary care provider when it comes to giving nutrition education, perhaps doing this from early on? And what do you think their role is in perhaps a shift of culture? Because this is something that I'm personally very interested in, and I think it's a point that might not be addressed quite explicitly by a lot of people.
An excellent question. And I guess one of the points that I would make is one of the reasons I use that cost reimbursement model for the other expenses would be for a practice to actually 2 experts that I would add into a primary care practice would be a nutritionist and a psychologist. And both of those would be beneficial in the issue of nutrition and mental health. And we actually did build in psychologists into a bunch of practices. Again, it really wasn't reimbursed, and we had to abandon it for economic reasons. But we found it to be incredibly valuable. And I think that given the understanding of nutrition's impact on our health, it certainly would be beneficial to integrate that skill set in a primary care practice as well. Is that responsive?
Any additional questions? Okay, then I will get to ask mine. Thanks once again, Mr. Connolly, for a really amazing talk. I thought it was very interesting. And in particular, I thought your idea about coordination between insurance companies and primary care is a interesting and novel solution to a pretty serious problem. And like all ideas that I like, I'm going to try and poke some holes in it. So I was very curious because everyone here is here because they're interested in the humanistic side of medicine. But in general, people do what they're incentivized to do, and businesses even more so. So two questions. How do you propose to incentivize insurers to pay for primary care? Or in other words, why is it good business for insurers to contract directly with primary care providers rather than use the current system that we have right now?
Well, I would say the evidence is already out there, which is the fact that the largest employer of primary care doctors in America is Optum. And they know that if they have an army of primary care doctors, that the patients become taken care of more efficiently. Another example is the movement for direct primary care. The Medicare Advantage plans are also big users of employed primary care. And so they understand that giving patients access actually lowers the overall cost of healthcare. And one of the sad things about there is no incentive for health insurance companies to lower the cost of healthcare. They basically make their money off of processing bills. And so the higher the bills, the more money they make. And so the idea that they're trying to save people money, and so I would use federal law to mandate this. I don't think the insurance companies are going to be excited about this at all. But we need to do what's best for the country. And most large employers are self-insured, and all they use the insurer for is a TPA. And that TPA makes their money off of processing claims. The more money they spend, the more money they make.
Yeah, that sort of leads into the follow-up question that I had, which is whether insurance companies can be persuaded to do this voluntarily versus whether regulatory action is required.
Yeah. They would never do this voluntarily.
I suppose the other follow-up question that I think a lot of people might be thinking of is the logical conclusion of your argument a single-payer healthcare system, or is there still room for private enterprise in the insurance market?
Oh, I'm very much in favor of a private market. I mean, the primary culprit in fee-for-service medicine is Medicare. They basically build the coding system, and so I certainly don't want to give them more power. So I'm very much, there's no need to eliminate the private role of insurance. It just needs to be incentivized to do the right thing. Right now, it makes money from spending money.
Yeah, I think that's it. At least I personally think that's a compelling argument. Anyone else in the audience is willing to? Emily?
Yeah. So, hi, I'm Emily. I'm also a first-year medical student, and I had a similar follow-up question to Matthew about single payer. But my other question that I noticed as a topic that wasn't in your presentation was about the growth of private equity in healthcare, especially over the last 10 to 15 years. I was just curious if you had any thoughts about what can be done about that, or is that too big of a fish to fry for the main point of your talk, which is about like starting with smaller changes and using that for incremental progress?
Right. Well, actually, one of the most destructive places for private equity has been in hospice. They now for-profit hospice is 50% of hospices in the United States. And the fastest growing segment of that is private equity. And the reason and I may have missed this on the slide, but the reason they make the money is because of coding. And so if you eliminated coding from a hospice, they couldn't manipulate their payment, and they'd get paid the same as everybody else, and they'd be out of healthcare as fast as could be. And so I'm not sure that the private equity has really gone into a lot of medical specialties. So they're, taking over orthopedic groups, and they're taking over cardiac groups. The sad thing about that is, and people are just going to have to learn, it's going to be like Stewart Hospital all over again, which is that the first generation will make a lot of money out of selling out, and then the next generation of doctors in the practice are going to get shafted because they got to carry the debt. And meanwhile, the private equity guys make a bunch of money doing the transaction. So I mean, it's just buyer beware in these situations. But I mean, I've seen ophthalmology groups, franchising. The ER groups are all franchising. Have any of you watched the series The Pit? I mean, what my favorite episode of The Pit was when the doctor was coaching the residents on how to upcode. Because to me, it was the ultimate example of the corruption of healthcare. There's a question in the back.
Larry. Yeah, you should probably wait for the microphone.
Thank you very much, Mr. Connolly. That was a great talk. Do you think that doctors' incomes are inflated?
No, I actually think they're underpaid. They're just paid to do the wrong thing. They're paid to do procedures and tests. They're not paid to take care of a patient.
In a healthy economy, how much do you think a primary care provider would receive? How much would a vascular surgeon receive? And how much would an insurance rep receive?
Well, in my book, I have a very specific range for primary care, and that's 350 to 500,000. For cardiovascular, I think 750 to 800 is probably reasonable. For the I almost feel as badly about right now those revenue cycle executives make more money than doctors. And so there are a lot of bad actors out there, including CEOs of health systems. But, I think that one way of dealing with the salary issue, and, you have to let capitalism do its thing. But one of the things we have is the ratio of the salary of the executive to the salary of the average employee. And that's become a more popular metric. And putting some parameters around that is another way of diminishing the gap. Is that helpful?
That is helpful. I guess part of the question, which I didn't ask explicitly, is that in your model, proceduralists like an orthopedic surgeon or an ENT physician would still be paid significantly more than primary care, but all would be reimbursed better than they are currently?
Essentially, yes. Because I think if they devoted their time to the right things, it would cost healthcare less money. It isn't so much about what they get paid as, I mean, we're spending $1 trillion a year on billing. You know, you could redistribute that $1 trillion on salaries. I mean, there is just so much waste in that system by doing unnecessary things.
Thank you.
I had a follow-up question to Claire's question. In order to get market forces to sustain the salary increases that physicians, well, as a future physician, I'm certainly not going to say no to it. I think so my question is, how do we need to restructure the incentives in the healthcare economy in order to make that something sustainable by breaking up insurance companies to give physicians more negotiating power, by consolidating what's the driver of market forces that's going to result in that sort of increase?
Well, I think that there is an interesting option for our country to look at, and that is, you know, Kaiser actually is an excellent model of healthcare, and they own their own insurance company. And so they're basically dealing with themselves, and they're dealing with how they distribute the premium to each other. But most physicians are unwilling to become part of an integrated delivery system. But yet, if you look at some of the best healthcare in America, I'll say this for my friend Bob, the Cleveland Clinic or the Mayo Clinic, I happen to like the Mayo Clinic, they are team-based integrated networks. And the difference is that neither Cleveland or Mayo have the insurance element integrated into them because it's too difficult to enter that market given the capital structure of health insurance. But there have been small examples of that, like Kaiser in Pennsylvania. But that is one way to redistribute the dollars in a rational way that works. What I'm suggesting is that if we just fixed primary care, a lot of other things would start naturally coming. I mean, it may turn out that the other proceduralists would like to get a salary too, and there may be a way of arranging that works for everybody's best interest. And it may also result in a way of people being more willing to be integrated with each other. Is that responsive?
Yeah, that's a terrific response. I actually wanted to ask a question of something that I've been thinking about as a potential way for us to have a market-driven reduction in the cost of care. And I wanted to know what you thought about a insurance company whose stakeholders, whose shareholders are effectively doctors. Would that solve the incentive issue of insurance companies denying necessary care? And would it direct care dollars into providing the best quality care for patients?
Well, that's what Kaiser is.
Yeah, I was wondering if you think that model is something that can be expanded on a broader scale and be sustainable with that higher scale.
The problem is culture.
Mm-hmm.
You know, most physicians don't like being part of an integrated group. And that just is the way it is. And, you know, the problem is you lose your autonomy, the larger the group you're in, et cetera, et cetera. And then the problem with insurance is that it's scale. It's so scale driven. I mean, Kaiser is very ineffective outside of the markets that they have the penetration. and they can't transplant themselves and be effective. And United has just really been effective at spreading itself.
Thank you for your talk. So I'm curious about your thoughts on I guess something suggested to me by my good friend's mother, who's been a liver pathologist for quite a long time. So she's very familiar with, I guess you could say, the corruption and all the issues with billing and codes and everything in the insurance system. And her advice to me, as coming from the patient side of things, 'cause I'm not a medical student, was to basically procure disaster insurance. So to be prepared for things like emergency visits and really extreme surgeries, but then to pay out of pocket for other routine things like primary care visits. And I'm curious what your thoughts are on this and if there's kind of a way for this to fit into the system you're proposing.
So this has to do a lot with the economics of insurance. And so a general principle of the economics of insurance is that the highest deductible you can afford is the most efficient thing for you to do. It doesn't make any difference whether it's home insurance or whatever, because small claims cost more money to administer, and therefore insurers are happy to get rid of the small claims and give you a better break on the overall cost of your coverage. Now, the problem with healthcare is, again, some idiotic fraud and abuse rules relative to billing. So what most people don't understand is that a doctor or a hospital cannot bill a patient and not collect their fee unless they can prove the patient can't afford it. And a lot of patients don't want to give you the information to prove they can't afford it. And so the way this applies to your high deductible is that you're going to make charges for that care, which is 2 to 3 times what it really costs. And you don't have a lot of latitude to negotiate that down unless you can prove poverty. And so that's just part of the insanity of the pricing system in healthcare right now. Which, by the way, there is no fraud if the doctor gets paid. And so all the fraud and abuse in primary care goes away because there is no ability for them to manipulate the system for payment. Was that helpful? I think the short answer to your question is that you can't buy the product that the person was recommending. It doesn't exist.
If there are no further questions, then once again, thank you, Mr. Connolly, for your time and a very excellent talk and wonderful answers to our questions. We really appreciate you coming, and thank you so much.
Well, thank you for this initiative and your interest.
Yeah. All right.
Thank you very much. Bye.
Bye-bye.